Diffuse parenchymal lung disease, DPLD, is the new name for interstitial lung disease, ILD. Don't worry about it, it's all about the same thing. And the problem with DPLD is that it's pretty low yield, because DPLD is a category of diseases, not one disease. In fact, there's 100 histopathologic variants of DPLD, and they all come together, to which we refer to as one common disease, diffuse parenchymal lung damage, or DPLD. What I want to do in this video is show you DPLD as a single disease, especially how it relates to obstructive lung disease. Then give you a categorization method for some of the higher yield DPLD diseases, and finish off by talking about those diseases that are high yield enough for your test. So DPLD is a lung disease, and I want you to see it as completely separate from obstructive lung disease. Obstructive lung disease is going to be things like COPD and asthma. But it also is different than cardiogenic causes of pulmonary edema. DPLD is effectively scarring of the lung. It doesn't matter which form of DPLD you have, it all ends up with the same thing. Restrictive, scarred lung that does not oxygenate well. Let's talk about it in general. How you get DPLD is highly variable, and it has to do with the etiology, and there's a lot of them. We're going to go over a few you have to know, and definitely do not commit to memory all the different letters. And you probably remember them, the COPs and the BOOPs from step 1. Don't have to know that, just know it as DPLD. And what you'll see is a person who presents, often it is very chronic and insidious. It's a chronic, insidious development of hypoxemia and a dry, hacking cough. You may also hear dry crackles. That is, there's no fluid there, but they have some sort of crackles. But most often, you get here because someone has cough or hypoxemia and you're just not sure why. And what you end up with is a restrictive pattern on pulmonary function testing. And what you do that for is to find out if they have COPD. But then they end up having the wrong test on pulmonary function testing. The workup for DPLD begins with an X-ray, which you're going to see an interstitial pattern. You might see a reticular pattern, it might be nodular, or a combination of the two. That doesn't even tell you you have DPLD, it just says, hey, there's something wrong with them lungs. The best radiographic test for diagnosing DPLD is a high-res CT. And you remember when you did pathology or micro, you cut those sections really small, so when you looked under the microscope, you had great resolution. That's what a high-res does. High-res lets you look at the interstitium, gives you a high resolution so you can find out what's going on. The words you're looking for is ground glass opacities. Ground glass on high-res CT is indicative of DPLD. The pulmonary function testing can be obtained, and what you're doing is really ruling out other disease. You're going to see a restrictive pattern. That is the opposite of obstructive lung disease. And I remember obstructive lung disease, one, because it's more common, and two, because it makes more sense. What you're looking at is the FEV1 over FVC. In COPD and asthma, resistance takes time to overcome, so the FEV1 goes down because you can't get a lot of air out in the first second, and the FVC goes up. In DPLD, because it's restrictive, you don't have a lot of vital capacity, so the denominator goes down, and there's no resistance to blowing it off. So the FEV1 over FVC is often elevated or normal, and the diffusion of oxygen is way low, restrictive and hypoxemic. If you're going to come to the best test, the best is going to be a biopsy, which usually means video-assisted thoracoscopic surgery. Very few DPLD diseases get worse when you biopsy them, so for the most part, if you want to know what it is, you got to get a biopsy, because the diagnosis is made on pathology. The problem is that it doesn't really matter what you have because the mainstay for all of these diseases is steroids and the prognosis generally remains poor. But there are other forms of anti-inflammatory medications that might be of benefit, such as DMARDs and biologics. But in general, the DMARDs and biologics are just not used enough to know if they have benefit. DPLD is fairly rare, so you're not going to see it that often, which means that we don't have the opportunity to do a real workup for it or any studies for it. So what you're looking for is chronic cough hypoxemia restrictive pattern, high-res CT, you can biopsy it, and most often the answer is going to be steroids. All right, this is how you can see DPLD in general. Let's talk about an approach for categorizing. At the center we have idiopathic. And idiopathic is usually what you're going to end up with because most of the time you just don't know, but you give it some steroids. The only thing you need to know about idiopathic is that if it's acute, less than 6 weeks, you have acute interstitial pneumonitis. If it's chronic, as you expect, that's greater than 6 months, you have idiopathic pulmonary fibrosis. And then existing separately are going to be things like drug-induced. Drug-induced is going to include bleomycin, chemoman, and amiodarone. Long half-life, pulmonary fibrosis, and also radiation. And these are color separated to recognize that radiation is not a medication, but you can still get it, pulmonary fibrosis, as a product of giving someone radiation. Another form of known cause is going to be rheumatologic disease. And we're going to talk more about rheumatologic disease in rheumatology, so we're not going to go through these. Just know that systemic lupus erythematosus, rheumatoid arthritis, and systemic sclerosis can cause pulmonary fibrosis. In this lecture, what we're going to talk about are 2 different sets. Something that is called primary, and don't worry about why it's called primary. I've eliminated a lot of the diseases in this category, so you don't have to learn them. But in this category is sarcoidosis. And also environmental exposures. And environmental exposures, the big ones you got to know about are going to be asbestos, hypersensitivity pneumonitis, and the pneumoconioses. Pneumoconioses is going to refer specifically to silicosis, berylliosis, and coal miner's lung. So we're not going to talk about rheum, we're not going to talk about drug-induced, just recognize that they're there. And we're not going to talk anymore about idiopathic because so long as you recognize that it is DPLD and you have a time frame, you have your answer. Now, is it more complicated than this? Of course it is. There's so many more letters and diseases to memorize that it's just not worth the squeeze. Keep it simple and you'll be able to operate DPLD at the MS3 or even the resident level. Let's talk about some of the ones that we really need to know about. The first one being sarcoid. Sarcoid is an autoimmune disease, and it primarily affects women who are black. Non-white, but mostly black. In sarcoid, you can have a very variable presentation. Sarcoid can be simply asymptomatic bilateral hilar lymphadenopathy. If you see big fluffy stuff in the center of the chest, on an X-ray obtained for something else, you should think this is pulmonary sarcoid. And most of the patients that have this are going to simply resolve spontaneously. But people who get sarcoid, of course, can then develop the insidious hypoxemia that leads to DPLD. But sarcoid isn't just in the lung, so the extrapulmonary manifestations are going to include things like heart block, Bell's palsy, and erythema nodosum. What you're going to see then when you make the diagnosis is you're going to start with a chest x-ray. and you're going to see the bilateral hilar lymphadenopathy. It looks like lymph nodes that are central and they're bilateral. Now, sarcoid has to be the diagnosis of exclusion, so you're going to get the high-res CT, and sure enough, you're going to see ground glass. And then you're going to do PFTs to rule out something else, and you're going to see a restrictive pattern. And then you're going to do your biopsy, and what you're going to see is non-caseating granulomas. You're wondering why I said all those same things I just said for DPLD. I'm doing it to remind you what the process is for making the diagnosis of these things. The treatment is going to be with steroids. Especially if you have systemic signs. Now, somewhere in here, if you're going for a 290, if you're trying to rule in cardiac sarcoid without pulmonary involvement, you'll need a cardiac MRI to identify it, and then get a biopsy of the endomyocardium with the sarcoid in it. Learn this as a pulmonary disease, bilateral hilar lymphadenopathy. The other big one you have to know a lot about is asbestosis. Asbestos exposure. And the thing is that this is an actual structure that gets in the lung and hangs around. And what it does, it really increases your risk of cancer. The patient is going to have some exposure, and that exposure is going to be shipyards and construction. So if you see in your vignette any mention of shipyards, what they're talking about is asbestosis. And the thing is that it takes about 30 years for the asbestos bodies in the lung to do anything. So you need to have 30 years or more of exposure. The problem with this is that they have a disease now. They got exposed 30 years ago. They don't remember 30 years ago. And so it becomes very important to look for the risk factor once you found the disease, not really the other way. But if you identify pleural plaques on X-ray, or you diagnose mesothelioma, chances are they had asbestos exposure. The diagnosis is going to be made on imaging. And what you're going to see are the pleural plaques, a cancer, a malignancy, and you're going to tap it. By that point, they already have the cancer or the pleural plaques. It's not like you can do anything about it. But if you were to do a biopsy of the lung, you'd see the barbell bodies. You'd actually see the asbestosis. And the problem here is that the only thing you can do is really reduce their risk. So if you know they've had exposure but they don't have pleural plaques, you tell them to stop smoking. And if they do have cancer or if they develop pleural plaques, the only thing you can do is stop smoking. Just know about asbestosis because it's popular on the test. It's popular for mesothelioma on TV with lawyers. But really, it's about getting the shipyards and the construction industry clean now. We're having the employees wear masks so they don't get asbestosis in their lungs. There's not a whole lot you can do for them now. All right, that leaves hypersensitivity pneumonitis and the pneumoconioses. Less you need to know about those. So let's break it down to what you do. Silicosis, borreliosis, coal miner, and hypersensitivity pneumonitis. What you need to be able to do is associate the risk, that is, what job did they do, to what type of thing did they inhale, and look for that in the vignette because that's really going to be the answer. For silicosis, you're looking for sandblasting and rock quarries. And the thing you need to know about silicosis is because it usually presents in the upper lung zones with nodules. It looks like TB. So you have to rule out TB and you have to give that TB screen annually because the incidence of TB is higher in people who have silicosis. Borreliosis is even lower yield. Just know that it's in the aeronautics industry. People who build and manufacture electronics. There's not really an association you have to know about. Coal miner's lung is Pretty obvious, you have to be a coal miner. What you're looking for is Kaplan syndrome. And so if you have arthralgias and pulmonary fibrosis, get the rheumatoid factor or an anti-CCP and look for rheumatoid arthritis. Super, super low yield. Hypersensitivity pneumonitis, so that's the one you want to be able to identify. You learned it probably for step 1 as bird fanciers. The thing is with hypersensitivity pneumonitis, it is antigen mediated. So step 2 is likely to not give you the person who owns a bunch of birds. Instead, it's going to be the person who goes to work during the work week and develops symptoms of pneumonitis, DPLD. But then they go on vacation and it goes away. Or they have a long weekend and it goes away. Because it takes about 24 to 48 hours to set in after exposure. But then it also takes only about 24 to 48 hours to go away once removed. So what you're going to see is a regional or temporal DPLD. They go to work, they get sick, they come back, they're not. But not in the same day, but over the course of days. They only have problems when they work in the barn, but not at home or the office. They only have it when they're surrounded by their birds, but if they go away and visit their mother-in-law for a week and there's no birds, they don't have the problem anymore. This one is so important because rather than giving steroids and saying suck it up, you simply remove the environmental exposure and the disease goes away. So what we learn? DPLD in general. Restrictive pattern, cough, hypoxemia, get the high-res CT, biopsy when you need to. Chances are, if they ask you for treatment, it's going to be steroids. You can start categorizing all of DPLD, and I've listed for you the ones you should be able to identify at the very least, not even necessarily make the diagnosis for in our organizer. What you do need to know a lot about is sarcoid, and that is going to be the asymptomatic bilateral lymphadenopathy or extrapulmonary symptoms. Biopsy is a non-caseating granuloma, and you're going to use steroids. Follow up with a cardiac MRI if that's what you think is going on. Asbestosis, shipyards, stop smoking. Silicosis, rock quarry sandblasting TB, borreliosis, spaceships and computers, coal miner's lung, you worked in a coal mine, and hypersensitivity pneumonitis is people who have problems throughout the week when they go to a place. When they leave that place for a couple of days, they get better. Hypersensitivity pneumonitis does not need steroids. That is DPLD.